Here we go. All right, so chapter 4, communication and documentation. Let's turn my pencil back on. All right. All right, so communication obviously is the transmission of information to another person. Effective communication is an essential component of pre-hospital care. Without getting into details, you have to be able to communicate with somebody. Stage fright is not good for EMS. You have to be able to ask those embarrassing questions, those important questions, those personal questions to be able to get the information that you're going to need in order to provide the proper treatment. I like to call patient assessment and history taking like interrogation, because really we're trying to gather all this information to be able to get a differential. So verbal communication skills enable you to gather information from a patient or bystanders, coordinate and present instructions to other responders. So being that person in charge, you being the higher license levels in advanced EMT, have to be able to give orders to EMTs and EMRs and first responders of what their job function is going to be when you are on scene with them. Understand the nature of the scene and the patient's problem, right? You have to have good verbal communication skills to get the information you are looking for to come up with a differential diagnosis. Hold on 1 second. All right, I'm back.
You're on mute.
Thank you. Documentation is written or electronic record of care that becomes part of the patient's permanent medical record. So this helps others who may participate in patient's future medical care. Right. So that's why it's so important. We are the first responders. We see what the physicians and the doctors don't see. We see these patients at their sickest and start doing treatments in the field. So you have to paint that picture for them. None of these 2-liner or 3-liner narratives. I'm talking about writing a decent narrative to paint that picture that they need to be able to continue their treatment. They need to know what you've done, what's worked, what hasn't worked, okay? What has been done for medications, what is changed in patient status for the better or the worse, right? Medication administration, dosaging, right? They need to know how much has been given. Right. All this information is very, very important in your documentation. The PCR is very important. The drop downs that everybody hates, those are very important for protocol development. We just talked about that in last class, right? Complete patient records, guarantee proper transfer of responsibility, comply with requirements of health departments and law enforcement agencies, and fulfill your organization's administrative needs. Billing is very important. CQI. CQI develops, if you have a good CQI program and have a good training department and education department, your CQI builds training programs, right? It finds out what a majority weakness is, and we build programs off of that, right? That's what a good CQI program does. It all fits into clinical and education, tie in hand in hand. Radio and telephone communications link you and your team and other members of the EMS, fire, and law enforcement communities. You must know what your communication system can and cannot do, and how to use it effectively and efficiently. You have to know how things work, right? The difference between UHF, VHF, 800 megahertz, utilizing different radio systems that are out there. I say Nextel, but AT&T has different programs as well, right? And I can show you guys one on the screen here too that we use down here to communicate, and it's called AT&T EPTT. So I'm sure you guys can see my phone, right? I communicate with our dispatch center through this, an app on a phone, right? Action Ambulance uses Zello to communicate with dispatch for Action Dispatch in Massachusetts. And they have something called a gateway that goes between repeater systems and internet-based radio systems, called a mimer as well. So there's a lot of interesting things that are out there that are utilized in in the radio telephone communication link to get things across, right? So know what your system uses, right? Know the difference between UHF and VHF and how that works, right? Have an understanding of how dispatch centers work. Therapeutic communication involves the art of skill of communicating with people on what they may be, which may be one of the worst days of their lives. When you walk in to a patient's home, what are they expecting?
Help.
Help from a professional, right?
Yeah.
And everybody in this room is a paramedic. They don't know the difference. They watch TV, and what does TV portray everybody as? Paramedics. Okay. So you dress yourself. You know, my name is Kevin. I'm a paramedic. Or my name is Owen. I'm an advanced EMT with Newfield Rescue. I'm here to help. What is going on today? Right. So build that rapport. Right. Eye contact. Very important. Right. Don't look around the room while having a conversation with the patient. Get right eye to eye and have that contact with them. Get down to their level. Right. Pediatrics, especially. Elderly, get down to the level, whether it be on your knees, kneeling down in like a catcher's stance, whatever you want to do, but don't stand and hover above them. I'm 6'4". So imagine me going up to a 6-year-old or 5-year-old and I don't get down to the level and start treating. Right? I'm going to scare them. Right? I'm going to look intimidating to an elderly person. Right? We don't want that to happen, right? So get on the level and introduce yourself and be sincere. Right? Clothing, huge. Culture, educational background, environment, right? Voice tempo. If I walk in sounding like a complete jerk because I've had a bad morning, what do you think that's going to do to the patient? Are they going to instill trust in you? Because they're at their worst moment. That's why they called you. Their worst moment could be a sprained ankle. That's the worst they've ever had. Worst pain ever. You're like, well, suck it up and walk out to the ambulance, right? No, we can't do that to them. We can't tell them to suck it up and walk. Our job is to make sure we prevent any kind of further harm. So CSM, splinting, ice, pain medications like Toradol, you can probably you can administer if you're within your scope of practice for pain management. Nitrous oxide, if you guys carry nitrous oxide, that's within the advanced scope of practice in New Hampshire, right? For pain management. So there's things out there that you can utilize, but treat your patient. As far as age, culture, and personal experience goes, shape how a person communicates. Tone, pace, volume of language reflect the mood of the person and perceived importance of the message, right? Body language, eye contact are generally affected by culture. Okay. I am not telling you to learn everybody's different culture that's out there. I don't even know them all. But if you don't know, ask. Okay. You can tell a lot by the way someone looks at you, how they talk to you, how their body language is, how their demeanor is, and what's going on. That's all part of your assessment, part of your visual you're looking for. Example of some differences in nonverbal communication. Hands on the hips is considered a sign of hostility in Mexico and Argentina. Islamic and Hindu cultures avoid touching with their left hand. Right? Some other ones here. Most Asian, African, and Latin Americans and Caribbean cultures avoid direct eye contact to show respect, while Somalians and Brazilian cultures, prolonged eye contact communicates honesty and interest. Slouching is considered rude in Japan and also in Northern European areas. Okay. So again, learn the different cultures that are out there and what people do. Remember, there are also some cultures as well that are out there that don't use any kind of like soaps, specifically like bars of soaps, body sprays, deodorants. It could be against their culture, so they could have bad body odor, right? Doesn't mean they're not cleaning themselves with water, but they might not be able to use deodorants because it's against their culture. It's their religion that they have. So again, understand the differences that are out there, and if you don't know, ask. Right? That's something that you can do. I didn't say they're not religion. Apparently Siri decided she wanted to talk. That was interesting. No. Apparently I thought I said that word. All right. Body language provides more information than words alone. I would say this guy right here is happy. The guy here is probably angry, right? Facial expressions, body language, eye contact, physical cues. If I'm standing there with a clenched fist down by my hip, do you think I'm angry? Maybe. Body language, look at it. Look how my demeanor is, how I'm presenting towards you. If I have an angry looking face and I'm holding, clenching my fist, I'm at a stance ready to attack, maybe it's time for you to kind of back off a little bit. Other noises, anything that dampers or obscures true meaning of message, literal noise or other factors that are there, right? So other studies of space, how distance between people affect communication. People have a bubble, try to stay out of it. Okay. The one thing I cannot stand the most, someone gets right up in my face and starts having a conversation. If I can touch you by reaching my hand out, you are too close to me. Right. That puts me in a position where I'm ready to defend myself if something were to happen. Right. Unless you're wanted or welcome to come in to my bubble, stay out of it. Right. For the most part. Now we are in EMS. Sometimes we do have to get close to people. But again, respect people's personal space. Verbal communication. Skilled verbal communication is an essential part of high quality patient care. We have to be able to communicate with our patients. But when communicating, don't use big, long words that they don't understand. Right? I can go all day with you today, like having a conversation with Jen since she's on my screen right now. And I can have a conversation with her and start saying big, long words. She'd be like, "What are you talking about?" Like to a child. I'm going to press around your umbilical on your abdomen and let me know which quadrant hurts. They're looking at you like, "What are you talking about?" I'm going to push on your belly. Point to where your belly hurts. Okay, good. Now I can see it. Right? Get to their level and have that conversation. Right? When you're asking questions, the most fundamental functions of the AEMT would be asking open-ended questions requiring some level of detail and response. Closed-ended questions can be answered in a short or single-word response. If I said to Jen, "How are you feeling today?" Right? That's an open-ended question, right? Do you have any shortness of breath? No. Close-ended. I want a short answer, yes or no. If she says yes, I'm going to say, "Can you describe how that shortness of breath feels right now?" "Well, it's kind of hard to breathe. It feels like something's sitting on my chest. I can't catch my breath." Okay, that's my open-ended question I'm trying to figure out. Figure out which kind of questions you want to utilize to develop your differential diagnosis. Differentials are not just utilizing skills. It's also how well you communicate with your patient to interview, or I call interrogate, the patient to figure out what is wrong with them, right? The mnemonics that are out there, sample, OPQRST, right? Associated symptoms, pertinent negatives, all those different things that are there. Okay. You can utilize those. They're there to help you. Sample is not a brand new EMT skill. I still write sample in my narratives. I've been doing EMS for 25 years. I still use the word sample in my narratives. Why? Because it's consistent and it's a practice that is utilized everywhere. Okay. This table here shows you different questions, and again, we already went over these together. Other types of questioning can reveal underlying issues, including the following payoff questions that were devised by AMTs in the field. Have you ever felt like this before? Have you ever felt upset about anything lately? Are you afraid of someone? Save this one for the privacy of the ambulance, okay? Don't start going that one in the back in the middle of everybody else. Have you been thinking about hurting yourself, and what happened the last time you felt this way? Okay. I could say to Sean, "Do you have any chest pain?" He goes, "Yes, I do." Does your chest pain feel, "I've had a heart attack in the past." Does it feel like your last heart attack? Yes. Okay. That's something to understand. Jen, you have any breathing problems? Yes, I have asthma. Have you ever been intubated before for an asthma attack? Yes. Oh boy. Now we are thinking this would be, we need to start doing some significant treatments now before they get him getting intubated. Okay. So ask those specific questions tailored to what you're looking for an assessment. So when we do cardiac emergencies, we'll talk about cardiac assessment, respiratory assessment. Can they go hand in hand? Absolutely. You can have one and the other. Right. There are many powerful communication tools when trying to obtain information from patients. Facilitation, encouraging the patient to talk more, provide more information. So I'm going to feed you some clues, some words to facilitate you giving me the answers I'm looking for. Silence, giving the patient space and time to think and respond by not speaking. Okay. So if I said to Jen right now, that since you're the only picture I can see right now on my screen until somebody else opens and talks, right? If I said to you, do you have any chest pain, shortness of breath, dizziness, nausea, vomiting, diarrhea, blurry vision, headache? And you say yes. Okay. Well, what was that yes to? I didn't give you a chance to actually think about your answer. Okay. I gave you information overload, question overload, and then I've lost you. All right. Now, someone of younger age might be able to give, let's say 18, 25, 35, 50, might be able to give you a great answer. Someone who's 85, 90 years old, and you go that fast, they're still stuck on how do you feel, right? So you got to make sure you give them the time to answer those questions. Reflection, empathy, clarification. If I don't understand something, hey, can you please clarify that for me? I don't understand what you're trying to tell me, right? Confrontation, making the patient who is in denial or in a mental state of shock focus on urgent and critical issues, right? I don't care about the fact that you had 15 kids 45 years ago. I want to know what's going on now. Why do you have chest pain? Tell me more about it and direct them into what you're looking for. I need to start treating now. All right. Interpretation, summing up the patient's complaint to confirm your understanding. Explanation, providing factual information to support a conversation. And then summarize everything. What are we going to do? When interviewing a patient, consider the careful use to touch and show caring and compassion, right? Touch is a powerful tool as long as they give permission to touch them, right? Cautiously and sparingly, right? The one thing that drives me up the wall is when an EMS provider starts calling patients dear, honey, right? Don't do that. Call them by Mr., Mrs., or if they give permission to call them by their first name, use their first name. You know, I hear it a lot down here. Everybody is like honey and dear down here. It's like, stop it. Call them by their name. They have a name. You know, if they want to call you honey and dear, that's fine. All right, sweetie, doesn't matter. I don't care. But we should not be doing that to them. Call them by their first and last name unless they give permission to do so. Interview techniques to avoid. Provide false assurance or reassurance. Ma'am, everything's going to be okay. I can't promise that, right? We're doing the best we can to help you. Can I promise that? Yeah, I can, right? Avoid unsolicited advice, right? Asking leading or biased questions. EMS bias is a thing, right? Talking too much, interrupting the patient, using why questions, using authoritative language, speaking in in professional jargon. Like I mentioned before, they don't care about the fact of all these big words. They don't understand them sometimes. Speak normal English to them. Okay, don't go all medical on them. Right? We can put medical words in our documentation, but when it comes to talking with a patient, speak normal. The presence of family, friends, and bystanders may also be valuable during the patient interview process. The one thing I cannot stand, though, is when you're asking the patient who's alert oriented questions and the family members are always answering all the questions. I need to hear it from the patient, but I will ask the family questions as well afterwards. Right? It may be different. Do not be afraid to ask others to step aside for a moment while you talk to the patient. Decide if having family or friends nearby will make the patient more or less anxious. So the golden rule to help calm a patient and reassure a patient is maintain eye contact, right? Watch her inflection, establish a good rapport, respond to the patient, anticipate and deal with fear, respect the importance of pain, respect and protect people's modesty, like when doing a 12 lead on a female, right? Don't do it out in the public where everybody can see because the shirt has to come up and the left breast has to be lifted, right? Never grope anybody. Always use the back of your hand to lift. Professional is lifting up like this, right? Groping is like this. We don't want to grope anybody. Tell the patient the truth. Never lie to a patient, all right? Don't ever do that. Use language the patient can understand. Be careful of what you say to the patient or about the patient to others. Be aware of your body language. Always speak slowly, clearly, and distinctly with them, all right? Don't go a mile a minute. They get confused. If the patient is hard of hearing, face the person so he or she can read your lips, right? Allow time for the patient to answer questions and act and speak in a calm, confident manner while caring for the patient, right? They can also tell when you're nervous. And if they see their professional helper to show up nervous, that becomes a problem, right? Yeah. They're putting their trust in you that you know what you're doing, right? If you're there as an advanced EMT and they require pain management, let them know. I'm going to be calling for a paramedic. They can provide a level of care that I cannot, which is providing you pain management to help with that pain. All right. I want to put an IV in place right now to help get prepared for the patient for you to receive pain medications. All right. Let them know what's going on and reassure them that help is on the way. And hopefully a paramedic will be available to assist. All right. So emotional intelligence, the ability to understand and manage your own emotions and properly respond to others' emotions as well. Right. I'm not telling you not to be empathetic. Sometimes we got to put things aside to be able to treat the patient we need to treat, and we can have a breakdown after we're done, right? We can release afterwards, but we need to be there for that patient. They're depending on us, right? Sometimes referred to as people skills as well, and people skills are not taught, right? It's something that you're used to using. Also can help AMTs diffuse conflict, build a rapport, communicate more effectively, and manage difficult situations. So we got to make sure that we can utilize that. Commonly understood to have 5 attributes for emotional intelligence: self-awareness, self-regulation, motivation, empathy, and social skills. So consider the following tips also to improve your own emotional intelligence. Assure how you react to stressful situations, assess, practice mindfulness, take responsibility for your actions. Consider how your actions will reflect others before you take those actions yourself. And there's a 5-step behavioral change stairway model that can help improve communication, build rapport, and de-escalate a situation. I'll give you those 5 steps. Employ active listening, display empathy, build a rapport, exert influence, and initiate behavioral change, right? These are things you're probably going to see on an exam sometime in the near future. You mean to go back or anything? You're writing things down. So communicating with specific types of patients as well. So difficult patients, and yes, they do exist, right? Patients can become hostile or defensive towards EMS providers. So diffuse potential escalating circumstances by staying calm, talk openly and honestly to the patient, right? And use open-ended questions to provide positive feedback, right? Never threaten a patient, ever, ever, ever threaten them. Never respond in kind to a patient who threatens or insults you. You're going to be called bad names, right? You got to have big shoulders and take it in, right? Don't go back at them. I've seen this before where providers become very rude to patients. I see it more in inner city EMS, right? But when you're out in the country, rural EMS, like Ospey Valley, up by where you guys are at Cannon, where you're up in Linwood area, Newfield, small communities, they know who you are and they know everybody. And you could mouth off to the wrong person, you may not have a job anymore. Or inner city, you might be able to get away with it, right? But patients deserve respect as well. Okay, and people talk. And by the way, EMS is a very small community, right? Everybody knows everybody from somewhere. Never assume an older adult is senile or confused, right? Don't assume it because they're old. They might not be at all. They might be more sharp than we are at times. Never assume an older adult, never assume communicating with older adults will be more difficult than communicating with anybody else. Let's see. Exercise great patience and compassion. I know we want to get moving. I know we look at our times and our on scene times, but the patient's stable. You have an extra 20 minutes on scene to make sure that they feel comfortable leaving their home to go with you. Make sure lights are off, doors are locked. I think they have their keys to get back in. Taking a bag with them, right? Don't rush people unless they have to be rushed if they're sick. All right. Allow plenty of time for the patient to respond to questions. Remember, older patients often do not feel much pain. Neuropathy kicks in, right? You may also be especially vigilant for objective changes as well. So just be ready for it. Okay. Remember, sometimes older elderly take more medications. It could be masking certain things. So get a good history. Talk to your patients. Children are difficult patients because, well, they pose communication challenges, right? Tend to protest pain vigorously, may be afraid of strangers, including you, may panic also when separated from their parents, right? So when we ever do an assessment on a child or pediatrics, we do toe to head versus head to toe assessments to gain their trust, and we get down to their level. When we get into pediatrics, we'll go way more in depth on peds. So in my EMT class, one chapter for pediatrics just took me 6 hours to educate. So I do a lot with pediatrics because it's something we don't do a lot of. And at the AEMT, you guys have a lot of pediatric protocols. So we'll be hitting pediatrics pretty heavily. So like they mentioned here, it's the big one, right? Eye level, right? 6'4" versus a 3 foot tall child does not work well, especially when they're sitting. You got to get down to the level. That's huge. Um, Smiles, be happy, with the family, the patient, right? Involve the parent in the child's care, right? The parent can hold the stethoscope up. The parent can do blow by oxygen. The parent can do a lot of things, right? They may feel more comfortable with. Let the parent become more active, right? Demonstrate on a sibling or parent. If I'm doing a stethoscope, I will take my stethoscope, put it up to my heart first or my lungs, then I'll put it up to them. Show them it doesn't hurt. Pulse oximetry, I'll put it on my finger first and say, look, it doesn't hurt at all. Then I'll put it on their toe or their finger, depending on the size, right? Use toys, distractions. Distractions are awesome. They have stuffed animals, things like that. I've had kids I've taken to the hospital. I say to mom, where's the kid's stuffed animal? Oh, I didn't think about grabbing it. Let them have it now. It keeps them calm. It's more security for them so that you can be able to do more procedures, right? Utilize the tools you have in front of you. Be honest. Children can see through your lies and deception. So be honest with them. Tell a child ahead of time if treatment's going to hurt. This might sting a little bit, like a blood glucose or an IV. I've used to be like a bee sting. They need to understand what it's going to feel like. It's going to be a poke, right? Respect the child's modesty. Don't start ripping off all their clothes. Tell the patient what you are doing and why you are doing it as well. So hard of hearing patients can be a challenge at times, right? Usually not ashamed or embarrassed by their disability, and they have normal intelligence. They can usually understand what's going on around them. Position yourself so the patient can see your lips. Let them read what's going on. Remember to maintain social distancing. If you know some basic sign language, great, right? I don't know it at all, but I know I have a piece of paper and a pencil or a whiteboard and a marker. And I can ask questions that way. Wearing a mask, also with a clear window, will also help allow patients to read your lips. Again, not a lot of us have those clear window type masks. So it makes it difficult when you're wearing a surgical mask. And now, as you notice, it's coming back again where people are going to start wearing masks on calls. Hospitals in Maine have already started it again because COVID and RSV now has been a big uptick, and the flu as well. Steps to take take effectively steps to take to effectively communicate with patients who are hard of hearing. Right? We talked about paper and pen. Whiteboards are great. Right? Notepads, whatever you have. Never shout and listen carefully. Ask short questions, give short answers. Right? So the next slide here has some basic sign language stuff here for hearing impaired. So help, hurt, sick. And learn, like I said, if you need to learn some of the basics, learn some of the basics. I'm not telling you to become ASL professional, but learn stuff that you might need to know. And if you have people that have hearing impaired in your area, then learn certain things. Right? Sometimes you'll know the frequent people you go to EMS calls for. Visually impaired, ask the patient if he or she has any vision at all. Right? Just because they say they're visually impaired doesn't mean they can't see sometimes it's shapes or shadows or whatnot. So ask them. Expect your patient to have normal intelligence and explain everything you are doing as you are doing it. As you're holding their arm, taking a blood pressure, you're going to feel it increasing on your arm. It might cause a little bit of pain, but it does deflate. Okay. I'm going to put this on your finger. It's called a pulse oximeter. And it's not going to hurt your finger at all. There's no pinching. All right, I'm going to put a tourniquet. I'm going to put a restriction band on your arm. It's going to feel pretty tight in your arm, but I'm trying to find a vein to put an IV in where you're going to feel a little bit of a poke. Okay. Try not to move for me. On the count of 3, I'm going to insert the needle into your skin. 1, 2. Don't do it on 2. Do it on 3 so they expect it. If they flinch and pull out, you lost your line. You got to do it again. Right? So have those explanations ready. Stay in physical contact with the patient as you begin your care as well. So again, you can talk to if the patient can walk to the ambulance, place his or her hand on your arm. Transport mobility aids such as canes with patients to hospitals as well. Please don't say we're not taking it with us. Now, they have an electric wheelchair. That's not coming with us. We can't. It won't work in the back of our ambulance. But regular wheelchairs you can fold. Okay, if they want to bring it with them. If I have family present, I'll say, can you bring this to the hospital for them? They're going to be on our stretcher, right? And you can do it that way as well. I don't like transporting a lot of things in the back of the ambulance if I don't have to because it becomes a projectile if you get into an accident, right? But again, use caution. Right? Guide dogs, right? We can transport those in the ambulance with the patient. That's allowed, right? Especially if they're guide dogs or if they're service dogs of some sort, right? They can be transported in the back of the ambulance as long as they stay on the stretcher. Usually is the best place for them. Remember, they are trained not to leave their owners and also not to respond to strangers. They are designed for that specific one. There was a lady, a female patient, I'm not going to say no names, that used to drive through a town on this road all the time in Maine. And she was a very fragile diabetic. So we would be called to this person on the side of the road all the time for an altered mental status. But her dog was trained to recognize when the patient's blood sugar got low. Don't know how they do it, but they knew how to do it. And they would come up to the patient and warn them your sugar's getting low. So they could call 911 and then we would show up and they'd be unresponsive in the vehicle. Interesting, right? So there are dogs out there that are trained to do certain things. So bring those dogs with you. This is a tough one. Unless you decide to speak 10 different languages, it's going to be difficult to speak with non-English speaking patients, right? They do make different hotlines you can call for translator hotlines. Like dispatch centers have the ability for those. But everybody has a phone nowadays, and Google Translate or Apple Translate is really good. You can type in what you want to ask them. Don't type long sentences, but speech text works pretty well as long as you can pronunciate appropriately so you don't have the wrong words going into it. but ask them simple questions, right? So smartphone apps, websites can help if you have that. Find an interpreter. And then also when you do your call-in by phone to the hospital, let them know there is a language barrier so they can get in what language they speak, so they can get an interpreter through their iPad that they have within the system. Another thing too, it's not bad, is consider learning other like common phrases or words in different languages that you use in the area. So if you have a predominantly Spanish or Hispanic area, learn some Spanish, some simple things. I'm not saying learn the entire language, right? Special needs patients, we're going to cover more of this later on, but never overlook the need for people with speech or communication disorders, right? Family members and primary caregivers who know the patient can also facilitate in the efforts as well. Touch and eye contact are very helpful in bridging that bridging as a bridging mechanism to use back and forth. So if you encounter difficulty with communicating with patients with autism, address questions to the caregiver itself. When we get into special needs, we'll discuss this a lot more in depth. So transfer of the patient care. Your reporting responsibilities begin when you arrive at the hospital. Effective communication with one healthcare professional in the receiving facility, all right, is a cornerstone of effective, efficient, and appropriate patient care. We got to make sure that we're being respectful, minimal interference, common priorities, common language or systems on uninterrupted critical care, right? What they're saying with all this is when you get to the hospital, you have to be able to give the appropriate report, right? What you have done, well, we start with the chief complaint, what your assessment showed, what treatments you've done, the treatments work or not work, what do you have for IV access, hand over a copy of your 12 lead to the nurse so they can show it to the physician because they want to see a baseline. Okay. If you have lab work, if you work as an advanced EMT or a paramedic in the Ospey Valley in New Hampshire, the hospitals pretty much require you to have labs and they provide them. And then you just draw a rainbow set of labs so they can run labs and they'll just stick a patient a second time. Right. There's other processes behind that, which you'll learn during your ride times or orientation if you decide to work at certain places and whatnot, how they do things. Right. So reporting is very important. If possible, a single person, the team leader, should coordinate the patient's transfer of care and report the patient information, right? If myself and two other people in this class are with me being the highest license level, if I had primary care, if I was the primary provider, I am the one that's going to give a report, okay? If I'm just there to drive because it doesn't require a paramedic level care and Jen's in the back, I'm not going to take over her story. I didn't see the patient. She was the primary out back. She's going to give the report, right? So when they talk about the whole SBAT thing over here, right? Right here, right? That stands for situation, background, assessment, and treatment, right? So when giving your handoff, you want to initiate eye contact, manage the environment, ensure ABCs, provide the SBAT, and then supply documentation behind it, right? So it's situation, background, assessment, and treatment. All right. Any questions to this point so far? We're going to get into communication stuff now. This is going to go pretty quickly for here because most of you guys have been using communication stuff for a while. All right. So if we're all set, we'll continue plowing through and get this done. Most EMS communities and systems today are based on radios. Okay. They're all regulated by the FCC. Right. I can almost guarantee you're going to see this right here as a question coming up in a test. Right. You must know when to use your communication equipment and what to say when you are transmitting. Right. Rule of thumb. Think before you speak. And when you go to talk on a radio, key the mic, right? Count to 5 and start talking. If you key it, a lot of people, what they'll do is they'll key the mic while talking and you miss the first part of the transmission because it has to hit a repeater. Give it a chance to hit the repeater before you start speaking to get the full transmission out. All right. Radio communication. A two-way radio consists of two units, a transmitter and a receiver. Right? So you can hear things and you can transmit stuff out. A channel is an assigned frequency or frequencies used to carry voice data communications, whether it be a primary dispatch center talking to like Sanford Dispatch or Carroll Fire up in the area that we're at up there. And then you also have operations channels that could be repeated or non-repeated. You could have local channels that you guys utilize as well. There's all different things that are out there. So know what your system runs and what channels you should be on talking with dispatch and ones that you can talk with other people on a scene that don't involve using dispatch. The frequency is the number of cycles or oscillations per second of a radio signal. A base station is something you'd find like at a fire station, at dispatch. Those are base stations, right? Ambulance bases, hospitals, and they have more power and higher, more efficient antenna systems. So big antennas on the roof than mobile or portable radios. However, now with some of the newer stations are all internet based and they go through Wi-Fi to repeaters and things like that. It's interesting how a lot of this stuff works now. Right? But base stations are like dispatch centers, things like that. Mobile and portable radios are found usually mounted inside the vehicle. Mobile radios are ones that are going to be sitting on, like in the ambulance, in the fire apparatus, things like that in the back of the ambulance, where a portable radio is something you carry on your hip or on a radio strap, right? Portable radios do not have as much power push out than mobile radios do, and bases have more power as far as transmitting capabilities. That's all based on the whole wattage. So a mobile radio usually operates at lower power than a base station, which is like 20 to 50 watts. All right, frequency bands are portions of the frequency spectrum assigned for specific usage. As you can see, VHF and UHF. So very high frequency, ultra high frequency. Then you also have your 800 megahertz systems, which are found a lot of times in cities. I am not a huge fan of that. A lot of times the people have to have repeaters in the apparatus for Chiefs vehicles. So I do not test a lot on portable radio stuff, by the way. So a portable radio is a handheld two-way radio, limited range between and low power. So usually 1 to 5 watts, carried by EMS providers when they are away from the vehicle. Radios that operate 800 megahertz, what they call a trunk system, are also becoming increasingly common in EMS systems. They're also very, very, very expensive to put into play. All right, so simplex is a push-to-talk, release to listen. Duplex is simultaneous transmission and reception. And a multiplex system combines analog with digital signals, simultaneously transmit 2 or more different types of information, voice, and telemetry. So a lot of stuff between simplex, duplex, and multiplex systems. So this is a repeater system. So as you can see here, if the ambulance here transmits, it goes to the tower or a repeater, and it can bounce from tower to tower to the station itself, or back the other same direction around back to the radio, right? Because this would happen if, let's say, mountain ranges are in the way or things like that, where you cannot do a direct from ambulance to dispatch or ambulance to hospital, right? They have to go up to a repeating system to be able to push out more power to get that signal across. Digital radio systems allow transmission of digital signals, computer or analog, which is voice. A lot of people have the trunk systems now where, I don't know if you've heard on the radio before, it sounds like garbled and you can't understand what they're saying, right? Those are more your trunk digital trunk systems. Digital is becoming very expensive, but becomes allows for that clearer voice transmission. I believe, remember correctly, New Hampshire police departments have gone digital, which makes it very expensive to purchase radios for that as well, digital and trunk system. So concern related to radios, communication, obviously. Distance is a big part. So as well, and success of communication depends on the efficiency of your equipment itself, right? So I'm not going to get too heavily into this stuff here. So maintenance of radio equipment, you should be doing your tests once, should be serviced once a year, and you should be doing your radio checks on a daily basis. Make sure everything's working. Please do not put drinks and fluids around your radio systems either. Last thing you want to do is drop any kind of fluid into it. Cell satellite telephones are becoming more common now to be able to contact dispatch centers, hospitals. I can't tell you when the last time I used a radio to talk to a dispatch center was. Not dispatch, I mean to a hospital. Most of the time, we use cell phones when we call in around here. New Hampshire, it's usually direct to a hospital via radio. I know that if you're transporting like main med, it's not usually done by phone, but the like Sanford Hospital's on by radio. In Mass, they have what they call CMed, where you call a specific like Northeast or Boston CMed, and then they transfer you to a hospital, talk to you via radio to a different channel. So it could be, again, learn your systems that you're there. There's so many different systems that are out there for communication. Digital equipment, telemetry capable of measuring vital life signs and transmitting data. So everybody nowadays should have the ability to transmit an EKG to a hospital. I'm assuming everybody has that now. It's rare that you see a facility or services that do not have the ability to transmit. New technology allows digital telemetry data from cardiac monitors to be transmitted via Bluetooth and or Wi-Fi, doesn't have to be Bluetooth, to a monitoring center. So what's happening with those is they'll either go to a fax machine or they'll go to like a specific internet-based program that the hospitals have the ability to access. Like Zoll has them, Physio has them, things like that. Other communication equipment, like interoperability stuff. So ever since 9/11, they went to a full interoperability system where we can talk with everybody. It allows multiple agencies to work together on frequencies. So this connects landlines, cell phones, computers, create a seamless, reliable exchange of information among all parties. So the U.S. Department of Homeland Security developed something called SAFECOM communication program. That's a set of international interoperability standards intended to develop compatibility across communication systems. So because after 9/11, a lot of this stuff happened. They found that they lost a lot of communications between everybody, so they had to work on coming up with a unified system. That's the whole interoperability deal. So like the state of New Hampshire went interoperability with that. They got a grant to replace every radio for every service in the entire state with portables and mobile radios years and years ago. So everybody would be on the same thing, and everybody had to have specific banks. So let's say it was like A through G bank in the radio. A and B and C could be for the department itself. Anything above that was a state required list you had to have in there so everybody could talk to everybody. So the Association of Public Safety Communications Officials International has established digital radio hardware standards known as the Project 25, or they call the P25 standard. That's something that's new, right? Also very expensive. Ensure that digital radio equipment manufacturers develop systems that are compatible with each other and with older systems currently in use. So they call it P25 standard. Computer-aided dispatch is what they call the CAD, so the computerized method of call handling. So this is data for dispatch can be sent directly to the EMS unit by data transfer. So they have something called MDT in vehicles, what's called a mobile data terminal, where they can send information from dispatch to a computer in a truck. And a lot of your bigger systems, like especially transfer companies, they don't even talk on radios anymore. They just literally press and route on scene, transporting that destination, acknowledge the call. All that is done through a MDT. which then lets dispatch know you're en route, on scene, transporting, so that way there's no need to have any communication via radio. They also provide mapping systems. They can also do text messages. I call them text messaging through those systems as well. So dispatch can send a message to you directly to that ambulance, and you can reply back via the MDT. So there's a lot of new technology, and the MDTs have been out for a long time. When I worked for Northeast Ambulance way back in the day, like 2005, we had them in the ambulances then. That's what we're talking about here. These are MDTs. They can be on laptops, or they can be like a fixed unit that's not portable like a laptop is, but everything gets updated, and you get like dispatch information, patient information, or that they can transfer all that information to you, what they have from the caller. So pretty interesting stuff. Backup communication strategies. The goal of backup plan is to ensure that you can maintain contact when the usual procedures no longer work. So landline backup to a link fixed components such as hospitals and public safety services. Other options are cell phones or other low band or high band systems. So if the computer systems fail, can we switch over back to a UHF system to have conversation with dispatch and be dispatch calls? So, all right, it is now another hour. We're at 9 o'clock. You want to just keep going? We have about maybe 20 more slides to go, or do you guys want to take a 5-minute break? It is up to you. But I need a general consensus. So somebody let me know what you want to do.
Keep going.
Keep going. All right. Sean took the lead. I like it. All right. We're going to power through this then. All right. So notification. Someone tells EMS an emergency exists. So 911 is now called, right? The dispatcher determines relative importance of the 911 calls. They go through and they assign appropriate response units. Bigger cities can do that. They can do dispatch by EMD. So if it's an Alpha Bravo call, they can send a BLS unit. If it's Charlie Delta Echo, they can send an ALS unit. They can do tier responses, things like that. And they also get all these determinants based upon questioning through cue cards and or on the online system. Right? This provides key information. Now, dispatchers are not medically trained. I say that cautiously, right? They have to follow a specific set of cards or cues. That's all they can do. They can't go outside of those and give any kind of treatment plan. All they can do is certain things. Like they can tell about the administration of aspirin. They can do things like that, but they cannot give a lot of medical advice over the phone. They have to follow a set of cards or cues. So dispatch communicates from the service headquarters with the responding EMS team. An appropriate crew is then contacted and informed about the call, then inform the dispatcher when you arrive on the scene. All right. So again, it kind of goes through the system. We go en route. Once the ambulance is on the way, the dispatcher may ask for additional information. So the real goal is to get that ambulance on the road. And as they're responding, then they can get more of an update on what's really going on at that point. The dispatcher will also give what they call pre-arrival instructions as well. And that really is for basic medical procedures, like, stopping bleeding. And things like that. All right. So we want to communicate during the transport as well. So communicating with the receiving hospital, right? We don't give a report until about your 10 to 15 minutes out, unless you're inner city when you don't have that kind of time. But it's always good to give them a heads up. One of the big things you guys want to pay attention to when giving heads up to the hospital, all right? STEMIs, strokes, sepsis alert, trauma alerts. They need to know those early because there's a lot of setup that has to be done prior to you coming in. So if you're working in the Ospey Valley in New Hampshire, where I used to work, I would call from the scene with a patient name and date of birth for pre-registration. So when we get to the hospital, we go directly to CT instead of having to stop and get registered so the CT machine can turn on and be used for that patient. Right? STEMI activation, same thing. Let them know early because they can start prepping for a cath lab. And there are some cath labs that are not operational at night, or it takes a half an hour for a team to come in. So giving early notification can help that patient get to the table a lot faster, right? So know your system, know where your trauma centers are. Trauma alerts require a lot of other different lab tests and different procedures to be done versus a normal medical patient coming in. Stroke alerts require a lot because they have to get telemedicine on board, teleneuro as well to kind of work with all that. So early notification. Communicating with the medical control to the hospitals as well. Again, we have the ability to utilize radios for that. Medical control really should be contacted over the phone. That way there, it's also recorded. A lot of radio transmissions can be recorded as well, but again, phone conversations are a lot better. It becomes more private. Plan and organize radio communication before you transmit. Think about what you're going to say before you say it. Now, you guys have been in EMS for a while, so you already have your radio patches down, right? For the most part. But now you're going to be adding in more stuff, more medications, more treatments, IV therapies, different skills, things like that. So your normal report that you used to give for BLS is going to change a little bit. So brief history, what's been going on, things like that. We'll go more over that together later. So the role of medical control obviously is either offline, indirect, right, or online, which is direct. Your indirect will be like your protocols, and understand how they are written. New England protocols are laid out for the most part the same, with just different treatment modalities inside of it. But other states have different flow charts and things like that, which are very confusing versus the current protocol sets that are there. For the New England protocol. So again, you have to go to the state you practice in, learn how they are written, and kind of see how the flow works. Medical control positions are base their instructions on information from the AEMTs. So we don't use 10 codes. They don't understand that kind of stuff. And honestly, I haven't used 10 codes in over 20 years. I probably remember half of them anymore either. Once you receive an order, repeat it back, right? So if I say to Sean as medical control, he's asking for nitro up to, well, not nitro is a bad example. You guys have the standing order. I'm trying to think what's med control in New Hampshire for it. We'll just make one up. We'll say epi. I can't think of one that's over there now. So let's say you want to give epinephrine 1 to 10,000 cardiac arrest, and you have to get medical control orders for that. He's going to call, and I'm at control. And I'm going to say, oh yeah, you go ahead and give 3 milligrams of epinephrine intramuscular, right? And that could be wrong. Then you're going to correct it. If I say, yep, you have permission to give up to 3 doses of 1 to 10,000 1 milligram epinephrine's, 1 to 10,000, repeat 3 times. He'll repeat that back to me, the order that I gave, as long as it sounds correct. All right. So you have to go back and forth. Never blindly follow an order that does not make any sense. Please don't do that. All right. Information about special situations. A small rural hospital may be better able to respond to multiple patients of a highway crash if notified when the ambulance is first responding. There are some systems. When I was working up in Vermont for a little bit, anytime we went on a medical call, we had to notify the hospital we were going to a medical call. So they knew what was going out when the ambulances were available. Giving hospital heads up for bigger incidents help them prepare, or they have to call in different teams. If you have a bus accident with 50 patients, right? And since Sean's on here, do you think Sanford Hospital can handle 50 patients at one time?
Absolutely not.
No. So they're going to have to divert to different hospitals, right? So that's when the MCI comes in and how many you can take. Can they take 4 green patients? Probably. Can they take 5 reds? Probably not. They can't handle that. We'll have to divert those either Biddeford or Sanford, right? I mean, Biddeford or Maine Med or Portland. So again, let them know early so we can start planning for that. Okay, if you have multiple patients or if you have sick patients, let them know. Because Sanford may say, divert to Portland. They're having a STEMI. We don't want them here. We're just going to ship them out anyways, right? Go to the most appropriate facility. So there are different things where you have to let hospitals know and keep them involved, right? And again, knowing your protocols and what you guys can transport to in your areas, that's a great thing, right? Critical access versus level 1 versus level 2 versus level 3 and what their capabilities are. I know that in the Ospey Valley, if I have a patient in labor and delivery, right? Frisbee shut theirs down, I believe. Wolfboro doesn't have labor and delivery, but Memorial does in North Conway. Laconia doesn't have it. They have to go to Concord. Okay, so you have to know your areas and where you're going to go. Use your system effectively. Standard radio operating procedures. Reduce misunderstandings. Keep your transmissions brief. I know we've all been listening to radios for a long time. You have those simple, some providers or fire commands that give like a 5-minute story over the radio, right? Concise, brief, to the point. All we need to do. We don't need to have a 5-minute conversation with ourselves, hearing us talk on the radio, thinking we're special. I can't stand that. It's the worst thing in the world when you have someone give a 5-minute radio report, right? So to the point, what they need to know, and then give them more of a report when you get there. So what they say here, develop effective radio discipline, all right? Written communication, documentation to kind of finish off with PCRs. Remember, these are legal documents, and I can't tell you when the last time I wrote a paper report was. I want to say that was in Maine in 2004, maybe 2005. And everything's been electronic pretty much since then. So PCRs are a legal document. They go with the patient, right? Their ePCRs are electronic. You just got to make sure that those reports are being sent to the hospital. Some systems, as you can see this one that's on the screen here, this is the Zoll program here, one of the Zoll ones for RescueNet. When you're done with the reports, either you have to print them and leave them at the hospital, or when you complete them, they get faxed over somehow or transmitted via email or whatever happens. Just know how your system works, right? And a lot of systems, you can't replace anything like controlled substances without having a printed report in hand anyways. All right. So because EMS systems track their own time, ensure to watch it set up is set with dispatch time at the beginning of your shift if your system's procedure. We use military time. We don't use AM, PM. Everything's military. Learn to write effectively and accurately is also an important skill. So good documentation and be thorough. Every report needs to be complete, accurate, and legible. Okay. I've seen people use templates to fill things out. I'm not opposed to people using templates. Just make sure you update it. Right. So don't forget to change male to female. Right. You can't put down a 25-year-old male complaining of abdominal pain, possible pregnancy. You forgot to change the word male to female, right? Also, if you're using speech text, double check what you say in there, because I can tell you right now, utilizing like Apple speech text and all that kind of stuff, I can flat out tell you that they don't understand every word that you say, and they don't understand a lot of medical jargon. So pre-read it, proofread it, because there might be some interesting things that populate. I've seen people do that before and just send them, and I'm like, what are you guys saying in these run reports? It makes no sense whatsoever. All right, this is another PCR system. This one here looks like almost like Tempsys or MEFRS, whatever it is now for Maine. So this is the image trend program here. This seems to be more common, but a lot of services like privates will make their own programs that are benefit to them. So, but a lot of New Hampshire uses Tempsys or the image trend program. I cannot teach you all the ones that are out there. My recommendation is learn the ones you guys already are at. If you work for a new company as an advanced EMT, just learn the different procedures and how things work. Legal issues of PCRs, no bias, no personal opinions should ever appear in a run report. The report should be complete, well-written, legible, and professional, right? For example, the patient was drunk and out of control. Your documentation might say, the patient presented with an altered mental status and stated that he had 8 beers today. That's factual. That's what he told you, right? There's no bias. There's no opinion. Is exactly what the patient said. Patient presented with an altered mental status. Medical terminology is being utilized. You determine that he presented with that by the fact that he's on AO times 4. All right. Use proper spelling, proper grammar, and accurate terminology in your run report. All right. I'm going to write a couple things down. for you. What does this mean?
Chest pain.
Okay. What about cerebral palsy? Okay. What does this mean?
Shortness of breath.
Okay. What about souls on board? Okay. You see where I'm going with this here, though? Right? Be careful with abbreviations that people utilize. All right. Instead of writing SOB, I'll put down difficulty breathing, or actually write out shortness of breath. Right. So be careful on certain things that you write down because they may have a different meaning. Right. So patient had positive CP, so he had positive cerebral palsy. Negative SOB, but you have a patient. There was a soul on board. That's utilized for airplanes and like things like that. Right. So be careful how you write things. Medical abbreviations again can be. There's a set. Medicare, I believe, has like a set abbreviation like book that you can utilize that they can bill from and all that kind of stuff. I write out all the words now with the technology nowadays and speech texting or speech typing like that. I don't worry about it anymore. I just say the words and then I go back and correct things that are wrong. I can't tell you the last time I actually typed out a full run report was. There are PCR serves 6 functions: continuity of care, legal documentation, education, administrative information, essential research record, and evaluation and continuous quality improvement. Right. This one, education and quality improvement tie in together. Okay. I think that works hand in hand. Right. The research stuff here, that's protocols. Right. That's development of new protocols, research. You can see how important this kind of stuff is. Legal documentation. Okay. Law. Continuity of care. I'm going to put the arrow like this here. I'm just saying that's moving on to the ICU, med surge, transfer to another hospital, continuity of care. All right. Admin stuff right here, that's billing. All right, a couple more slides to go. So document any changes in the patient's condition. If you close out your report and you find something that you missed, should you unlock it and continue typing it up again? Or do you fill out an addendum?
Fill out an addendum.
Addendum.
Yes, addendums. Never change what you have already submitted, right? That looks like you did something wrong. Okay. And yes, every time you unlock a report, it's documented in the systems that you're in. It knows you're unlocking reports. It knows when your system administrator unlocked a report. It knows when you changed it by time stamping. Fill out an addendum. Okay. Patient information collected on a PCR, chief complaint, level of consciousness. I'm not going to go in detail with this. We're talking about this in assessment. Vital signs, assessment findings, patient demos. Okay. Important stuff. When we talk about patient assessment, right, I'm going to make sure you guys really truly understand advanced level patient assessment. All right, we'll get more in that in detail later. The narrative section, I don't care what one you guys utilize. Narrative, DRAT, SOAP, SOAPier, D-chart, chart, whatever other ones that are out there. Just don't change your style, okay? If you bounce back and forth, back and forth, back and forth, and you get called to court, they're going to pull previous narratives that you've done and say that you're incompetent because you can't make up your mind, you're indecisive in what you want to use. Right? I was using SOAP. I changed over to chart because I worked for Stewart's Ambulance and they said we had to use chart. I switched over to that. Perfectly fine. I've been using chart ever since. I love it. And I'm not going to change it again for a long time. Will I add stuff to it? Absolutely. But my things is still going to say CHART with things next to it as well. All right. And that's what I've been utilizing since Stewart switched over to it, and I've never switched out of it. Right. So again, find which one you use. Don't be the person that changes over and over and over and over and over again, from SOAP to SOAPier to D-chart, DRAT, and all the ones that are out there. All right. Medical terminology, mainly derived from Latin. Okay. Like a headache is described medical term as cephalgia. So ceph being head, algia being pain. So looking at Latin roots. This is going to be very important for you guys when you start getting into pathophysiology, medical terminology, and things like that later on in upcoming lectures. So if you leave something out of your record incorrectly, do not try to cover it up, right? If you have something that you're writing down, if I put down like apple, I don't like that. One line through, put your initials above it, and then continue going through it. Never do this. Okay, that looks like you're hiding something, right? One line, initial, move forward. If you're using anything with paper. On a computer, hit delete and retype it. Simple. Right? Falsification causes poor patient care and then legal action. All right. Never falsify anything. If you forgot to do something, like check a blood glucose on a patient, don't make it up and say you did it. Right? Just put down blood glucose not obtained. Okay. If you didn't do it, you didn't do it. It's okay. Don't lie about it. All right. Minimum requirements and billing. Right. PCRs indicate why a patient may have needed emergency care. 911 calls are easier to bill. Interfacility transport have to have a reason why they have to go by ambulance. Okay. We can have that discussion at a later date. That'll take another 3 hours to discuss why and proper documentation when it comes to interfacility transports. When it comes to 911, you still have to document what's going on, chief complaint, and why they need immediate emergency care. But patient was complaining of toe pain, required transport to the local hospital for further evaluation by a medical facility. Okay. And the insurance companies are going to cover that because it's a 911 call. But interfacility transport, different story. Patient non-ambulatory, they get up and walk to your stretcher. I see Mike shaking his head. Yep. We've seen that before, right? So you got to be careful on certain things when you're documenting. Example of some significant findings that indicate medical necessity for an ambulance transport are that the patient is unresponsive or in shock, needs to be restrained, has experienced severe hemorrhage, requires emergency treatment while being transported. Right? Medical necessities also apply to the level of care provided for that patient. Signatures and other essential elements, right, to ensure your EMS agency is appropriately reimbursed for services provided. Right? I always tell people we're in the business of shipping, not receiving. Right? But receiving is still important because you're not going to be shipping anymore if they can't get money back in. Right? So you got to look at both sides of things. We need to provide great patient care, but I'm not going to start doing procedures to generate revenue. Right? I'm not going to be that kind of provider. I want to be a provider to be a clinician that's going to provide treatment that need to be done to treat the patient. Right? I could justify an IV on every patient contact that I have. Right? But is it the right thing to do? It's up to you to make that determination. I could find something, but could the patient have waited to the hospital? Maybe. It's all based on your clinical judgment. Health information exchanges, what they call HIEs, improve sharing among data among EMS and other healthcare providers. We're not seeing a lot of this stuff yet where I am down here or up there when I was working up in New Hampshire or Maine, but it's coming. All right. When you can type in a patient's name and access a database where you can get patient information. Right. But HIEs follow what they call SAFR or SAFER, which is Search, Alert, File, and Reconcile Framework. That's what that stands for. Search, Alert, File, and Reconcile. All right. 3 more slides to go, guys. We're almost there. So a common source of lawsuits document any assessment findings, emergency medical care given, efforts to obtain consent, right? And patient response, right? This right here, I'll circle refusal of care, is such a dangerous thing to do. You're more apt to be sued or be held liable if you do not transport versus you actually transporting. Okay. If all else, get the patient to go to the hospital, talk them into it, sell them on the idea, right? Because if you sign a refusal, your documentation has to be more detailed, I think, than it does when you are transporting somebody, right? And make sure you complete the PCR and always have a witness sign. And please make sure it's not your partner. Because you and your partner may have discussed en route to the call, hey, let's get this refusal so we can go back and get lunch. Right? And you sign, they sign, we don't need to go to the hospital, sign here, sign here. Witnesses are all signed by your partner. You go, patient's dead 3 hours later. Try explaining that. Try to fight it. Right? Now, relative signs, police department signs, that's perfectly fine. Your partner should not be. Reporting special reporting situations, obviously MCIs, use of mutual aid services, suspected physical or sexual abuse, infectious diseases, certain ones, right? Like tuberculosis being an airborne pathogen. Dog bites have to be reported as well. And then GSWs have to be, whether it's accidental or intentional. All right, last slide. So PCR and all information are considered confidential documents. $10,000 fine. Don't leave it out. Right. You may not have the time to complete a full PCR while at the hospital, but most systems will have what they call a drop report or a transfer report that you can leave information for the nursing staff. So they have an idea of who, like what's going on with the patient, what you've done. And you can finish your report and then that'll be transmitted, faxed, or you bring it back to the hospital later on that night. But they have to have an actual copy of your run report within 24 hours. And if it's a trauma patient, you got to get them there faster because they're going to be shipping the patients out for small local critical access. So, all right, let me just turn this recording off.